So we're making progress. We now have moved to a single agent to combination therapy. We've expanded the progression-free survival and very likely, we believe, the overall survival, although we need randomized data there. And so what are the next steps in terms of development? Renée, can you comment on the Calypso trial and what is being done in papillary RCC specifically right now with the SAMETA program?
Yes, of course. So the future seems bright for non-clear cell RCC. We're heading in the right direction with the SAMETA trial, for example, which is a phase 3 randomized trial that will be specifically designed for patients with papillary RCC, with MET-driven papillary RCC.
Yeah, so maybe I want to interact here.
Yes.
So what we've discussed earlier around papillary is that there is about a third of patients that have this so-called MET-driven disease. So it's not only mutation, it's about the ligand, it's about the amplification or the gain around chromosome 7. So these used to be maybe the lower grade papillary RCC, for which we know that there is a role of the MET pathway. So once again, it's a biomarker-driven trial in a rare entity, so very challenging to perform, but it's a phase 3, right? And so we're getting to combination there?
Yes, exactly. So we're getting to a combination that is based on this MET mutation amplification in papillary RCC. So one of the treatment is durvalumab, which is an ICI, with savolitinib, which will directly target MET. And the other arms were durvalumab and sunitinib as monotherapy. And this trial is made possible from the success of Calypso, which also showed promising results with the savolitinib, which was directed at MET in papillary RCC. And I think that's the most exciting trial we have right now.
Okay, so that's a biomarker-driven trial in a rare entity. Do we expect other trials to read out? I've heard about the Sunny Forecast. It's an academically led German study that enrolled a lot in Europe, so not only in Germany. Why is this trial important?
This trial is really important, and the name is very positive here. So we're evaluating nivolumab plus ipilimumab, which has had great success in clear cell RCC in patients with metastatic non-clear cell RCC who were untreated. And that's comparing versus standard of care for these patients. And we're really excited about the readout of this trial too.
Yeah, because we did have some results with nivolumab, ipilimumab in non-clear cell, but exactly. This one is randomized to standard of care and enroll all those variant histologies that we've discussed before. So hopefully we'll have results subtype by subtype, and we may be able to find out who are the ones who can derive benefit from the doublet IO strategy.
Exactly. Like you said, in the past, we've had retrospective data and also like some small cohorts in bigger trials that evaluated nivolumab and ipilimumab. But here we're really targeting non-clear cell with a big enough number to look at individual subtypes.
Okay, and are there other trials that we are awaiting from?
Yes, there's also the Fortune trial, which is a phase 2 trial evaluating tivozanib and nivolumab in patients with non-clear cell RCC. And these patients may have received up to 1 line of systemic therapy before enrolling in this trial. So I think these are the main big 3s that we're waiting for. On
top of the XL-based regimen combination that you mentioned. Okay, so we're waiting for randomized data, getting to the biomarker-based selection, getting to each subtype when it's feasible, especially papillary, that is the most common. But hopefully we'll have clinical trials also for other more rare entities, which really speaks to the fact that we need to have sometimes pathological review or making sure that those patients are referred to tertiary centers where they can have access to innovation, given these are rare entities with this small prognosis.
Yeah, and a global collaboration, because it's so difficult to agree within one institution.
Absolutely. Yeah. No, Laurence, you mentioned the STELLAR program. We should talk a little bit about the STELLAR program. So STELLAR 002 is a combination of XL092 with nivolumab in a variety of subtypes of kidney cancer. And I think there are non-clear cell cohorts in that trial. So it will be really important as that program goes forward for us to pay attention to the cohorts of each histology and how XL092 zanzalintinib with nivolumab plays out as a combination. Definitely one to look out for.
Exactly. So early stage there, phase 1 data, but hopefully getting to more advanced stage. And what is interesting to me is that we only discuss frontline. So what is your strategy in a patient who failed IO TKI regimen? How you treat them in second line?
Yeah, that's where when we have some data of the different TKIs. So, for example, if we have a patient with papillary kidney cancer, they've had lenvatinib, pembrolizumab in the frontline setting, then I would switch out their TKI and give cabozantinib in the second line setting. Think about trials. Always think about trials, right? We have a couple that are enrolling in the second line and beyond. I hate it when people limit the lines of treatment, but when we're on the lookout and it's on our radar, it's really important to think about for those patients as they come into those lines of treatment.
Well, thank you very much. I think it was very interesting to have your point of view. Obviously, this is a very rapidly evolving field, so we need to be up to date and make sure that we learn about those new trials that are up and running. We make sure that our patients that have those rare entities are being referred so that they can access to innovation, including in the adjuvant setting and hopefully in the future in later line.